Morning. Hope you are doing really well wherever you are. It's a little bit grey, a little bit wet, autumnal today. So now, if it's the morning for you and you may be going to work today, please, I just want you to know that all of these study clubs are recorded and I put them onto my YouTube channel. So, so just you can just look at this over again. It's a lovely case. I really enjoyed this. This is Gordon here, and I provided him with complete dentures. So you may know that my first point of contact with a patient is via Zoom or just by a telephone call, which I think is like super important because it helps to filter out patients that are not right for me. And if I'm not the right dentist for them too, I might be just too expensive. It might be as simple as that. So, um, so that's great. Anyway, this is my consultation here, and hopefully you're going to be able to hear me talking and hear Gordon talking. He's 87. He's been a dentulous since the age of, well, his late 20s. So I put down 28. And he's going to chat with me just now about what his wishes are. Let's go for it. Hopefully you can hear this. If there's any probs, just stick it into webinar chat so I know that it's not working.
Late 20s.
Okay. So so now so you must have been okay with some of the your earlier dentures.
Never with my bottom set, no.
And
Okay.
you haven't worn the bottom set dentures for the last 50
Since
years,
then,
actually.
really, I've not had a successful bottom set of teeth.
Right.
I've not been able to eat with them. They've
Yes.
not been comfortable to wear, in fact.
So he said to me, um, I've never been able to wear a lower set ever. And then his daughter just told me that he's been without teeth for over 50 years. And actually, if you calculate it, it's about 60 years. So he's never actually ever worn a lower denture. What are the chances of success, really, with this case? It's super, super low, isn't it? That's exactly what I was thinking. So I'm thinking about adaptation here for him. I'm going to be able to provide him with a good denture. This is what I said to him. This is the actual consultation. So let's go for it. There's what I can do is definitely guarantee you is I can make you something technically that will fit really well. It'll be made to the best standard, so it'll fit really, really nicely. However, I'm still reliant quite heavily on your adaptation to it and get
Yes,
so it's the lower even though um the we have the lower situation is totally different than the upper but
yes,
just because of the surface area
yes,
you can fit it onto and it
yes,
works better. In the lower, it's a horseshoe and it, like it's a
yes,
horseshoe shape and it's just got to fit into your mouth and work with it. So uh, it's there's still I reckon it'd be like 50% your work and 50% my work to actually get used to it.
well, I will give my 100%
Good.
effort to be able to use it. To be honest, I don't expect miracles, but it'd be nice if I could just wear them, even have to take them out to eat or, you know.
So the reason I'm doing that and happy, he's told me that he doesn't expect miracles. Um, by the way, Gordon's got his upper in there. He doesn't expect miracles. He's quite happy to just have a lower that fits, that he can maybe wear socially. He's not too bothered about wearing it at home or being able to chew with. So he understands that he's gonna have to a role to play. This is so important. I'm an Amit. You've asked me a question about how do I convince patients about my value, and during this, and this is all part of it. I don't try and convince them. I put the onus onto them. The longer I do this work, Amit, and the more patients and everyone and my referring dentists know that I offer this type of service, that's how it really grows and people want to have treatment from me. But what I'm trying to do here is to really align their expectations. So important. It's critical with removable pros. Absolutely critical. More so, I think, than fixed because I'm so reliant on the patient adapting to it. So this is another little, this is just through that Zoom consultation. I'm just managing Gordon's expectations. Let's move on to the next little clip of the video of me talking with him before he even comes in. With you never really ever wearing a lower ever since you were 20, it's sort of why is what we're going to do massively different? Apart from they'll be made really well and it'll give you the best possible chance of adapting. So it's a bit like fitting something, and if it's not very good, you've got a very big mountain to get over to get used to it, and sometimes that mountain's too high. And what I do is we bring the mountain down so it's lower, and so your adaptation's less to get over that adaptation curve and then get used to them.
I would be 100% happy with that.
Okay. So that's great. He's understanding that there's a learning curve, and I've just talked about how good dentures reduce that learning curve, but they're still difficult to get used to. They're a tool that the patient uses. They might look like teeth, but they don't act like natural teeth. So the cost as well. This is a really, really important thing that I can talk about. As you will know, my fees are really high, some of the highest in the UK probably for denture work. And I like to talk about this with the patients and give them an idea of how much things are going to cost. And so at the time, my fees were between £7,500 up to £14,000 for normal dentures, not implants. These are just conventional dentures, complete dentures. This is how I talk about it with the patient. Okay, so just the next thing I just need to talk about is costs. So the complete dentures that I make, they range between £7,500 and they can go up to £14,000.
Yeah.
So you'd be in that somewhere in there, but probably nearer the top end because of you. Technically, you'll be the most tricky, which is fine, but it just means I have to spend a bit more time with you.
I'm happy with that.
Okay. So that's great. He said he's happy with that, which is fantastic. So I can just move straight on and get on with booking him in for a consultation. Quite often I'd say I'm like on Monday this week, I had 5 new patient consultations, which were via Zoom or via phone call. And out of those 5, 2 of them want to come in, but the other 3 are put off by the finances. And it's really interesting, patients, even though I've got a website which shows the fees, and also the referring dentist often will send me patients in too, they just don't realize that the fees are on the website and they really don't understand the cost. So, like one of the patients referred to me this week, thought that the dentures, an upper partial would be £1,000, about £1,000. That's what his dentist had told him, even though on the website, my metal-based partial dentures range between 7,500 and can go up to, I think, about 14,000 for just a metal-based denture. So this is all done free and it just filters them out really quickly, but it's fabulous, for consent. Really, really good. But what I do find is the more I try to put them off learning how to use the denture, and get them really consented, and well, I'm not trying to put them off, I'm just trying to get them realistic. It does not put them off coming in for treatment, and taking up the treatment. Here we go. Let's have a look at him on presentation. Flipping out. Look at this. Isn't that awful? That tooth, that lip support. It's just classic. Teeth too far back. Horrible. Teeth set over the ridge. Just doesn't look real. And so, therefore, Gordon, he is, he just looks like he's edentulous. Don't like it. Um, how is he actually functioning? This is so funny. Quite a lot of patients don't actually use their lower denture at all, and just chew with the gum down here like that. And our diets are soft enough for him to be able to eat, and he can actually eat most stuff like meats and everything. So there's absolutely no functional issues, and he's done that. This current denture here is like 30 years old, but he's been doing this for about 60 years. It functions not the problem. It's really weird, isn't it? And look how worn it is. And that's just with occluding against a lower ridge. Not against his tooth, just against the lower ridge. What am I looking at when I'm taking my photos and looking in the mouth? I'm looking at frenal attachments here. How much depth have I got? The lower these frenum are, the more the seal will get broken. That's just basically what I'm thinking. He's got a flat lower. He's been edentulous for ages. 60 years. Super flat. So I look at it, that I then do a letter consultation process, as part of the proper consent. But on this letter, which is super important, I think, is that he wants an upper and lower well-fitting dentures. I said I can help him. My commitment is to delivering high-quality dentures that complement Rowan's excellent technical work, and that's about 50% of the task. The remaining 50%, the onus is on you, Gordon, learning how to use these. Because particularly in the lower, you just haven't ever worn one before. So that's like super important. And I think I was a little bit generous giving him 50%. I think the onus is more like 70% and 30% me. Super important. So what I did was as well here, which I think super, super important, his homework is to bring in lots of photos of his natural teeth, particularly if he quite liked his natural teeth. Wedding albums, fantastic, and everything just will help me produce really good looking dentures. We'll get the uppers in the right place, and as a result, get the lowers in the right place too. So here he did, he brought in tons of stuff. Look at that. He's brought in wedding album, loads of other pictures, and also brought in some honey. He has bees, and he brought in some lovely, delicious honey for us. So these are the photos, some of the photos. He brought in tons of them. Look at it. This is in his early 20s. Lip support, beautiful, showing us what his teeth look like. This is him getting married. Gives us ideas of his teeth, where they were, what his overall lip support was. It's fantastic. Even views like that, you can just see, the shape of the mouth. It's fantastic. So now these are my normal standard steps for making complete dentures. It's like we're taught at dental school: primary impressions, working impressions, jaw edge, try in, I might do a number of try-ins. So this is quite often flexible here. Fit and then review. But just look at the length of time I like to spend on these visits here, which I think is really important for training the patient and educating them, getting to know them really well. So important. Right, here we go. Visit 1, primary impressions. I love these transform edentulous trays. They come in 3 sizes. They're fantastic. This is a medium one. And what I do is I fill up the tray. I rehearse the tray in the mouth, and then I fill it with alginate here. And then I fill this syringe with another type of alginate, alginoplast. So that's blueprint X cream here, alginoplast in the syringe. And then what I do is I squirt this around the sulcus and a little bit into the vault of the palate, and then seat that together, and it sets together. And I find this much better than compound. It's lovely. Squirt that up into the sulcus, that just up into the vault of the palate. And it's beautiful, it's consistent, and really straightforward. I love doing this. And when I run the complete denture course, I'm running one later this month. Actually, next month, I'm going to be showing how to do these impressions. And also, the delegates can have a go on a patient too. You can have a little go. So this is the lower. I'll show you how I did this for Gordon. So this is his mouth, and I'll just show you this video and you can hear me talking to the patient whilst I'm doing it. Let's go for it. This is my head cam. Lovely, lovely. You're doing beautifully. Just let your mouth just rest as you are. Awesome. Lovely. You're doing beautifully. That's good. So that's number 1. I've got the second bit here. So I'm going to just gently rotate this in to your mouth. Lovely. Just lift up your tongue and let it relax now. I'm going to count to 5. 1, 2, 3, 4, 5. Lovely. Just gently with your lips there. Perfect. Hold that. So he just gently gripped it with his lips, and then I did a cheek massage. So that's the lower. And nice and consistent. I've captured everything I need. Full depth of the sulcus. And the beauty about this is it's really detailed. It shows the mylohyoid line. You can just clearly see it just here on the inside there, which is a really important point for marking exactly where I want the special tray to go, where I want these custom trays to go. So this is my upper primary cast and lower primary cast there. And then Rowan makes me the trays to fit on that. So custom trays for working impressions. The upper is 3mm short, the depth of the sulcus all the way round, back to the vibrating line. And the lower is like designed like this. And if you want to really study this and actually do it and work with your technician, then just follow these 6 steps in designing the special tray. It's fantastic. And this really does help to produce great suction on the lower denture. It's fabulous. So these are my trays there. So the upper is it's 3mm spaced for alginate. The lower is a close fitting tray, and I'm going to use zinc oxide. Let's go for it. Let's have a look. Let's fast forward 2 weeks. So this is what Rowan gives me. I asked for primary wax rims, these jaw registration rims, and I've got my custom trays. Let's do the imp. So what I do is, first of all, I pop my green stick onto the fitting surface of that upper special tray. So put that on, warm it up. I then press that up into the mouth there, and that helps to create these lovely guiding stops. So I can seat the tray square with my eyes shut in the mouth. I do that first, and then make sure it's not too long round the edge. So it's not touching and pushing up into the functional sulcus depth. I want it clear of that so that the alginate will go in there and border mold it functionally. So I then add some width on the posterior, on the back. So chunky bits of green stick, love it. It's lovely and warm and soft. Take that to the mouth. And I do some border molding, gentle cheek pulling. So just nice and gentle cheek pulling both sides, and then waggle the jaw open wide. And I want to feel suction on this when I take it out. It's great. And then I put adhesive onto that and cover that, the whole thing, with adhesive, alginate adhesive. And I mix up the blueprint lovely and smooth. And then here we go. This is a video here of me doing the impression for Gordon. And I'm going to follow these steps here. So let's pop it in. I rotate the tray in. Claire's got a little retractors in. I push that up so it seats onto my green stick stops beautifully. Claire takes the retractors out. You can notice the Gordon's sitting up. I'm pushing that up, and I'm going to border mold the lips and the cheeks. Nice and gentle, not like super hard, nice and gentle. I'm just thinking about what he's doing. He then waggles his jaw and opens wide. Really good. And then what I want him to do is to pretend it's his birthday and blow out candles. Really blow. Functional blowing. And then have a good, powerful yawn. And to exaggerate his movements. It's so important, these functional movements, because I want the end product to look like this. This is Gordon's mouth. Can you see that the alginate has been molded by him doing all of these functional movements? I'm not bothered about little bits of air blows like that. It's just no big deal. We've got a great functional impression. It's beautiful. Right down to the stops. Absolutely fantastic. So, and that's going to create a really good seal for the denture. And hopefully, whilst he does all of his functional movements and eating and talking and laughing, it's going to stay in situ. Exactly the same for the lower. Now, let's move on to the lower. I add green stick to this is the fitting surface of the tray. I add green stick to the lingual surface there, and also to the buccal surfaces. This is looking from above. You can see these lovely little stops, these little handles where the teeth are, where the teeth would go, so they don't get in the way of the impression. And then you can go E and ooh, lick his lip, push his tongue against the strut, and a good powerful swallow. I then add the zinc oxide eugenol to this. I'm now actually using Kelly's paste for this, because SS White, which I used to use, is not available. So Kelly's paste is really good. Let's take this to the mouth. And these are the movements I'm going to do, or ask him to do. Tongue out, ooh, E, push and swallow. This is with my head cam now, so you'll be able to hear my voice. Gently rotate this in. Lovely. That's beautiful. And just relax. Yeah, just lift your tongue up slightly. Lovely. That's good. And I'm going to bob this out now. So just close up a little. And then could you really stick your tongue right out now as far as you can and move it side to side this time. Lovely, and relax. Could we do the E's and the Oo's as well? E, ooh, really exaggerate. E, ooh, lovely and relax. Push against the strut with your tongue and relax. And have a good swallow now. You can close right down on your fingers. Brilliant. Awesome. So often Claire, who's my nurse, she'll have no mask on and she'll be further back, and the patient copies those movements. Crucial. Look at that, beautifully border molded, and it's just like this is what I produce all the time, just using these lovely set techniques. It's fantastic. So this is the impression here, just gorgeous, and that's great. So we've got some little comments here. Toby, hi, morning, Toby. Good to listen to you again, and great going into psychology of initial appointments. Thank you. That's great. So yeah, the psychology is like ultra, ultra, ultra important with complete dentures. So that's the impression, and this is, I just want the fitting surface of the denture to look just like that. We can start to develop the polished surfaces too. I also do a primary jaw registration at this visit. These are made on the first primary casts purely for helping Rowan set up the Gothic arch central bearing apparatus for visit 3. So it's not for tooth setting up this, it's just for recording how the patient just bites. It's not in centric relation, not interested in that at all. So I just trim that to the correct vertical and then fix it together like that. So this is what goes back to Rowan. I've got my working impressions and the primary jaw registration. So what Rowan does is he then pours these models, so that and that get poured, and then our working casts are produced. And then this is mounted on the working casts in the articulator, like that. And then the Gothic arch tracing is made. So this is what my technician does. You do, as dentists, we don't need to do that. We just send the dentist, the technician, this, and then he can then mount the working casts using the primary jaw reg for the Gothic arch tracer. Superb. Great. So let's fast forward now 2 weeks, because I like to give Rowan 2 weeks to the registration stage. And this is what Rowan provides me with. And this is what I ask for. I say, please, can you produce wax rims? I want the lower one to be a Manchester block, which is basically a wax rim, but with 2 wax blocks either side, not a full wax rim. It's super cool. This is for prescribing the tooth positions. And then also on the working cast, Rowan provides the central bearing apparatus for recording CR. Really good. This is what I do at the at this jaw registration stage. I like to cut a post dam. So I want to cut a post dam on the working cast, and this is the shape of it. It's like a keeper's bow. And I carve that into the working cast. I soak the model in some water and then use a Lacron carver and cut that in. So it's like a divot across the back edge of the denture to seal it. And this is the shape of the post dam, what I'm thinking about, right the way across the fovea palatini in the midline, and then right the way round the hamular notch into the side. So we've got like a double seal here and here. When the patient opens wide and waggles the jaw, it's going to be sealed in. And then I push in the wax into that area. I then carve the wax rim, and I use this carving recipe, which I think it's so important. I follow this recipe in this set order. I do my lip support first, and then incisal plane, occlusal plane, buccal corridor, centerline, and then the vertical. I do that all in a set order using those lovely photographs he brought in of his natural teeth, and also with his lips together to get good lip support too. So I'm looking at the photos as well as the patient doing this. You know, I'm using my Fox's bite plane. This really helps me. The Fox's bite plane helps me to get the interpupillary line parallel with the incisal plane, which is really important. This is often how most people's teeth look there. I also want to get it parallel to the alar tragus line too. Now, I've looked into this just, over the past 6 months, and I found a really interesting paper looking at anatomical, what are all humans like, in terms of their upper occlusal plane to the alar tragus, and that most humans' upper occlusal plane is parallel to the alar tragus, but the actual the tragus, this is the alar of the nose, but I'm looking more at the bottom end of the tragus now. I've been doing it too high and carving too steep an angle here, so I'm just going to be trimming it slightly lower. But with Gordon, I treated him about 18 months ago, and it's just a little bit steep. I'm always trying to see things that I'm doing wrong and trying to correct things or improve things. So these are the trim rims. You can see, look at the improved lip support though. Doesn't he look better? Oh, his face just sits better and looks nicer, doesn't it, there too? So once I'm happy with that and done all of those 6 steps, I then attach a face bow. Just one sec. I do have some questions here. So Emma, why do I choose ZOE over in the lower impression? Emma, I love zinc oxide in the lower. It's got more body than alginates, but it really doesn't matter too much what you use as long as it's border molded well. Next question, Dr. Mangwesh. Hi, sir. Regarding the upper primary tray, how short is it made from the vestibule, and are the edges, especially the edges of the primary tray, in contact with the mucosa? Of course, Mangwesh, the primary tray, the primary jaw edge is quite often a bit too long, but we trim it back when we're fitting it back onto the working cast. Rahul Court, I feel the problem that I've faced with Manchester pivot rims is not being able to give support to lower lip. So yeah, with the lower Manchester rim here, sometimes I can't tell whether the lip support is okay at the front there, but that does not matter, Rahul, at all, because the lower teeth are always placed over the lower ridge. That's the correct position for them to be. We know the resorption pattern, and the crest of the ridge just sinks down like that. So the necks of the teeth just go straight over. So I don't need to assess the lower lip support at this point. It's the trying, we can do that, and we can alter that if we need to, but it's very rare that I need to do that because the teeth just go over the ridge at the bottom. So next, what I do is I do a face bow on the upper rim. So that goes in the mouth. Can you see I've used my Manchester blocks just to secure that upper rim in place? And he's just holding that and biting together just to secure it. And then I can attach the face bow assembly to that, which I think is really useful, and it's very quick. It just helps me to mount the upper working cast more accurately in a similar position to the patient there. And then the next thing is I can photograph, make sure I get a really good photo of him smiling. And then this is what Rowan gets. He's got that lovely photo of the natural teeth, and he's going to copy that arrangement as well as the carved rim. So during I'm still at visit 3. I'm still at visit 3. So, and this is before everything goes back to the technician. So before everything goes back to the technician, I've got my working casts, which have been mounted using my primary jaw registration. I put on my newly carved wax rims at my new vertical dimension, set the vertical of the articulator. I take that off, and then I put my Gothic arch tracer on and set the vertical of the Gothic arch tracer to the height of my newly carved wax rim. So I now then can do my central bearing apparatus. So I put on my China graph mark, take this to the mouth, get Gordon to move around all over the place, and he can go to CR, which is fantastic. Look at that. It's so precise here. I can then put a plastic disc over here with a hole in it, right over there, over the tip of CR, and I stick it on with some wax, take this back to the mouth, reseat it, inject that in, like that, fix that together, and that is set. So that is visit 3 done. There, like that. Exactly. So it's all fixed together. So what goes back to my technician? All of this goes back to my technician. So these are duplicate casts of the working casts. That was used to mount my working cast using the primary jaw registration from visit 2. So just ignore that, Rahul, there. These are my working casts, the actual proper working casts. So the upper rim there is mounted. That wax, this face bow is used to mount the upper rim. And then my jaw registration that I've done with the central bearing apparatus mounts the lower. And then this can set the vertical. That's really good. Also, please mention what material was used for duplication. Rowan uses agar jelly, warm agar jelly, duplicating medium. Loads of it. I love to have duplicates of my working casts. Super important. So this is Gordon here now. And so Rowan looks at that, sets up the teeth, and this goes to try-in. So let's look at this. This is the try-in here. And what I'm always thinking about is I want the upper teeth, and this is an Alma gauge here, which is quite useful for measuring the distance between the upper incisal papilla and the labial surface of the upper anterior teeth. I want it to be within 5.5 and 12.5 millimeters in front of the incisal papilla. That's the range that people have, natural people have. So here we go. So this is the upper and the lower. You can see it's quite class 2, division 1. Quite a lot of patients, certainly in the UK, are like this. Yeah, it's quite common. So that's the try-in. Let's go for it. So visit 4 now is the try-in. So I pop the try-in in. It looks great, doesn't it? And I'm thinking, yeah, that's really, really good. I put in my lower, got him to bite together, and he just did not go into the CR position that we recorded on the Gothic arch. Now, this is really, really important to know. I love the Gothic arch. And I love recording CR, and I find that CR in most circumstances, and this is the only one out of thousands of complete dentures that I've done that has not needed it. He's habitually always eaten with his mouth in a slightly strange position because he's never worn a lower, and I think he's habitually just wasn't able to go into CR. You know, he's been chewing like this. So dentistry is always full of curveballs, isn't it? You know, we always have new things that happen because we're dealing with people that are all individual. You know, genetically, everyone is unique, and so one size does not fit all. We're not like cars or machines. So I've got to just do some lateral thinking, and I've got to do this often in my work. Even now, sadly, you know, at the age of 55, having been a dentist for over 30 odd years and being a specialist and doing this for ages, I'm still encountering things that happen, curveballs. And this is what makes dentistry really hard to do. So, but anyway, I've got to think laterally. So I thought at this visit, I'm going to do another Gothic arch, but I'm going to record his tapping point, his chewing point. I'll show you what I mean by that. So this is, I put my chinograph mark on. Let's take this to the mouth. Forwards and back, forwards and back, and then side to side. And just go anywhere, all over. Just really go for it. Absolutely brilliant. Lovely. And then forwards and back, forwards and back, forwards and back. Good stuff. Okie dokes. Now, just tap together, just wherever, you know, where you want to bite. You know, if you had dentures, top and bottom, just tap together where you want to be able to chew with. So I got him to move around in his normal position, all different excursive positions, which would go back to that CR position. And then I got him to tap together exactly just wherever he wants to be, just in his most comfy position. And then I marked it with articulating paper. So this is me with some articulating paper. And open, tap together where you want to chew with. Hold that position. And so let's have a look at this. You can see, look at that. So that's CR. So you can go forward and back, side, side, go anywhere. But also, this is his tapping position. That tapping position is really just so consistent there. So that's his habitual chewing position. Let's call it MIP, maximum intercuspation, just to save. So what I did was I put my disc right over that tapping position there, and then waxed that up onto it so it's stuck on. So there, pops it into here, got them to close together, and interestingly, he went straight into that hole. Cool. So this is these are the two different positions. This is my visit 3 jaw edge. He's further over that way, there. And then this is visit 4 where he's further over that way. This is going to correct that bite, or that's what I was hoping. So squirted that in. I also did another jaw edge at this visit as well, with on the try-in of the upper, and also the lower pivot at the right vertical. But he flipping crunched it really hard because he's so used to biting onto this lower ridge and chewing and whatnot. So it didn't matter. I just fixed it together. But when we move forward, I changed this slightly. So we'll fast forward to visit 5 just in a minute. But I'll show you what goes back to the technician. So all of this goes back to the technician. This here is going to remount the lower to the upper. So it's going to remount this from CR to that new MIP position. So that lower working cast here, this is how it was originally. And then Rowan remounted that lower, my technician, and then got the bite and moved the teeth, re-waxed the teeth into the correct bite position. So Jan Morrow's asked, are these Enigma Life teeth here? Yes, they are. Celia has asked what she said might be a silly question, but why would you use CR all the time if it's okay to use a patient's habitual MIP? It's not a silly question, Celia, and this is a really common. This is something that's really is discussed a lot, Celia, is whether we should use CR or whether we should use MIP for complete dentures. And the reason that generally I use CR for complete dentures is it's so reproducible and we get that such a positive position on that Gothic arch tracer, and patients really learn how to use it. So I find it is like super reproducible. When I've tried using the tapping points though, because I did that for a while, particularly after I came back from Japan, learning from Dr. Abe, because he likes using the tapping points, I found that I had a few bite problems. You know, quite a lot of my bites were not spot on when I went to try and. So me personally, I prefer CR. But if you talk to Dr. Abe, he prefers using the tapping point. So it's personal opinion and it's not a silly question. But I love CR. I think it's more accurate. So let's have a look at this. So Rowan did the new wax trying on bases, on light cure bases, because he crunched through, the other one just to make it a little bit more stable. We took that to the mouth and it was great. He closed straight into MIP like that. Look at that, isn't it? It's just gorgeous. He looked so much better too. So it was lovely. He loved it. So then we'll fast forward to finish. Rahul, you're talking about how does he dupe these things? So yeah, we duplicate the working casts, and Rowan processes the the actual dentures on duplicates of the working casts. He uses agar, and I love keeping these working casts. They're stored upstairs, just so we've got them, just in case we need them in the future, because we often do. These are the upper and lower complete dentures finished. Look at the lovely positions of the teeth. They're quite light, they're 19 grams. And Rowan's characterised them too, just putting some stains, some cracks in. This is using OptiGlaze, GC OptiGlaze, beautiful. Looks fantastic. Just like natural gums. Secret acrylic tinting systems. So Celia has said, the bite blocks were class 2, 1, but the try-in looks class 1. Is this because of the change from CR to MIP? Yes, absolutely. You're dead right. Well spotted. So, the two positions are different now because he sort of made himself into a pseudo class 1. Absolutely dead right. So yeah, these are the teeth. Beautiful. It's so great working with a super technician. Lovely extended dentures. We extend right up over the retromolar pad. This area is where the buccal tongue contact position all sits down beautifully in the mouth. These things. Lovely occlusion. So let's go to the fit and delivery. So pop them in and really lovely and stable. It's beautiful. So, and that's lovely. Bite together like that. There. So, old denture, new denture. That's it. So, not massive but much better lip support, but still quite subtle. That, it's lovely. I love changing these people. Just makes them look younger and different and better. As we get older, this is his original lip support. This bit grows, gets longer. So I've just taken it further down. Essentially looking at that, there may have been a touch more scope for bringing the teeth out slightly. Maybe I've just been a touch conservative, but it was quite a jump from what he had originally. Now, this is super important here. This is a little trick, which is like a total top secret little trick. I like using these metal filings. This is iron filings here. And particularly with patients that may have bite issues, and if I want to develop balanced articulation on these dentures as good as possible. So what I do is I pop this in, and I quite often will do this at the review visit. So once the dentures are comfortable and I've made them and adjusted them, just to get the bite perfect, I mix up this carborundum with toothpaste, pop it onto the teeth there, and get the patient to grind around and try and mill them in the mouth, and just say, don't swallow this, you can just spit out, and I'll put a bit more on. And because these are Enigma Life teeth, they're hard. The posterior teeth are made of composite, and so they're really quite hard. So they need to do this for about 10 minutes. But I'll show you my head cam video of me doing it. Let's go for it. Right, together. Lovely. Yeah, just do that. Forwards and backwards, side to side. Yeah, really going for it. And then if you find the top one gets loose, just bite it back up. Lovely. That's great. So I do that, and I ask them to really work at areas where the dentures feel like they're tripping, because what's really important to understand is that we can't achieve true balanced articulation on an articulator with dentures. It's so important. There's differences between the articulator and the mouth. So there's soft tissues where things are spongy in the mouth, whereas we've got solid models on the articulator. You just cannot get true balanced articulation. You can get it close, but it takes time to equilibrate. So this is quite a nice trick. So these are the occlusal surfaces of the teeth after I've done that. Can you see, if you look closely, let's focus further in, how he's ground away some of these surfaces there and almost accelerated the equilibration process. So it's fantastic. It's really good. Great. So now it's 18 months since I treated Gordon. He's had esophageal cancer, recurrence actually. He'd had it previously, which had got sorted, but it's recurrence. But he's still well. I rang him up last week just to see how he's getting on, and he said, "Look, Finn, I'll be totally honest with you. I wear the upper all the time, and at home I eat with it without the lower in at home. I'm lazy," he said. I'm lazy. So, but when I go out socially, when I'm out and about, always wear them, even, for going out for meals with my family too. So, that's really good. So, it's amazing, isn't it? And if I'd not, let's go back right to the consultation and that Zoom consultation and the discussions with him. If he'd have entered into this treatment thinking that these dentures are he's going to be able to wear them all the time, no problems at all, then I would have failed. Even doing all of these technical bits, I managed his expectations really well here, and he totally was on the same page. He totally understood what was happening. Now, I get into difficulties with patients, and I still do, if we're not on the same page. I may think they understand what I'm talking about, but sometimes they don't. And sometimes when they deliver them, it comes out of the woodwork. So dentistry is so hard. We've got to be almost like a psychologist too and really read our patients. So my message today, I think, is to just really try and get to know your patient and try to drill into that wish list and really say, look, you know, I I'm not going to be able to make that lower work well. It's up to you to learn how to use it. And if you really want it to work, then implants are the only solution for you. Stuff like that is really important. Thank you. Now, Rahul, it's just wonderful that you've been joining me from India. It's ace. Please, could you? You've just asked me about whether Rowan could demonstrate characterization of teeth. Yeah, we can do that at some stage in the future. And there's another question here from Suarez. Sorry, I cannot pronounce your name properly. It's Irish, and I've really messed it up there, Suarez. But there was a significant undercut on the mandibular secondary impression. How does Rowan handle those? The undercut on the impression is blocked out. Simple as that. It's blocked out. Bryn, thanks for an interesting case. I have a case that fits so well with Gothic arch, created a fantastic occlusion. At review, needed no adjustments. This is him using Gothic arch for the first time. Excursions break the seal, absolutely. So doing excursions will do that. So doing that is great. Thanks, Suarez, as well. Anyway, so today has been this. So my next time I'm going to be doing this thing is going to be the Thursday, October 9th. I'm going to do a partial metal-based partial denture case next time. These are the rest for the year. I am running couple of courses now later in the year, October 2, 3. We've got 9 delegates on that. I don't really like too many more than that because it's just a lovely number. And then we've got a partial denture course later on. We've definitely got spaces for that too. These are 2-day courses. They're expensive, but really good. And then I've got loads of in-house stuff next year, 7 different dates for different things, running complete dentures, RPDs, immediates, implant overdentures, and a revision day for people that have done courses with me. I've also got other speaking engagements as well. My next one is going to be in Holland, just here in December the 12th, with some other British speakers. Super excited about that. I'm also going to be in the States twice next year, in Arizona in January at the SSC. I'm going to be doing a very little Directors Day, but because I'm potentially going to be helping them with their study clubs, that'll be like a Dragon's Den thing for me. And then I'm going to do a full day in Texas in February. I'm super excited to do that. Roman's going to be with me too. But also, interestingly, next year as well, I'm going to do 2 full days in London. This is like big venue. It's not with a demo case, but I'm going to talk about my disasters and how I got out of them. It's going to be hard for me to do this, but I'm going to bare my soul and show you some really bad cases and how I got out of them too. Can't wait to see you next Thursday, October 9th. You stay well, and this is recorded on and I'm going to put it on my YouTube channel later today. Thanks a lot.